Okay, let's unpack this. You know, in healthcare, there are some conditions that just seem to touch everything. They sneak up, they're serious, and they can completely change patients' trajectory.
Yeah.
Acute kidney injury, or AKI, is absolutely one of those. Whether you're revising for exams, working on a busy ward, or just trying to understand a complex patient presentation, understanding AKI is critical.
It really is. And it's surprisingly common, often complicating seemingly unrelated conditions. When the kidneys suddenly falter, the consequences ripple throughout the entire body.
Exactly. So today we're doing a deep dive specifically into AKI, drawing from some really detailed revision material you've shared with us. Think of this as our mission to go through this information, pull out all the essential high-yield nuggets, and make them crystal clear and memorable.
hmm Especially if you're trying to nail down this topic for revision or, for clinical practice.
Our goal is to help you see the structure within the detail, to connect the dots between what AKI is, what causes it, how you spot it, how you manage it.
And why getting it right matters so much for patient outcomes.
Yeah. Let's jump right in, starting with the absolute fundamentals. What is acute kidney injury? At its core, it's a sudden, significant decline in kidney function.
That's right. It's a clinical syndrome involving a rapid decline in the kidney's excretory function, its ability to filter waste and balance fluids and electrolytes.
And this happens fast, right? Hours or days.
Exactly. Over hours or days, not weeks or months like chronic kidney disease.
And the key markers for this rapid decline that we monitor are what? A quick increase in serum creatinine?
Yeah, serum creatinine going up and a reduction in urine output. Creatinine is that waste product from muscle that healthy kidneys filter out.
So if the kidneys aren't working, creatinine builds up in the blood. Makes sense.
Right. And urine output is how the kidney gets rid of excess fluid and waste, so less urine is a major red flag. We also look at eGFR, the estimated glomerular filtration rate, another way to gauge filtering capacity, especially over slightly longer periods.
So it's not just one number, it's a constellation of findings indicating the kidneys aren't doing their job. And the framework for understanding the severity of AKI is staging.
The most commonly used system is KDIGO.
Okay, how do we break down these stages?
KDIGO staging is based on those two main parameters: the change in serum creatinine from baseline and the rate of urine output.
And you stage based on the worst one.
Exactly. You stage a patient based on whichever parameter gives them the highest stage.
Okay, walk us through stage one. Mildest, yeah.
Stage 1 is the mildest. Creatinine increases to 1.5 to 1.9 times the patient's known or estimated baseline creatinine.
Okay.
Or it has an absolute increase of at least 26 micromoles per liter. That's 0.3 milli-GDL within just 48 hours.
Wow, that's quite specific. And urine output.
For urine output, it's less than half a milliliter per kilogram of body weight per hour, 0.5 milli-GDR, for a sustained period of 6 to 12 hours.
Okay, so less than like 35, 40 milliliters an hour for an average adult. That's not much.
Not much at all.
And stage two, more severe.
Stage 2 means the creatinine is now 2 to 2.9 times the baseline.
Okay.
And the urine output criterion tightens to less than 0.5 millikilori for a longer stretch, at least 12 hours.
Right, getting more serious. And stage three, the most severe.
This is the most severe stage. Creatinine is 3 times the baseline or higher, or there's an absolute increase of at least 40 milligl, or the patient has already started renal replacement therapy, like dialysis.
RRT initiation automatically puts you in stage three.
Yes. And for urine output, it's less than 0.3 millikilogr for 24 hours. That's barely any urine or complete anuria, meaning no urine output, for 12 hours or more.
So, roughly speaking, stage one, 1.52x creatinine jump, or that small absolute rise. Stage two is 2-3x. Stage three is 3x, or needing dialysis.
That's a good summary.
And urine output goes from 0.5 for 6-12 hours to 0.5 for 12 hours to 0.3 for 24 hours, or basically nothing for 12 hours. The memory tip might be just remembering those creatinine multipliers, 1.5, 2, 3.
That's a helpful way to structure it. And KDIGO also provides specific diagnostic criteria that overlap with stage 1, that creatinine rise of 26 per ml in 48 hours, or a 50% rise over 7 days, or that low urine output for 6 hours.
So those are the thresholds that officially diagnose AKI.
Exactly. And then the staging tells you the severity.
Right. And staging is crucial because it immediately gives you a sense of how sick the kidneys are.
Which dictates how aggressively you need to investigate and manage the patient.
Okay, that covers what it is and how we grade it. Now let's get to the why. What causes AKI? The material breaks this down into the classic 3 categories.
Yes, the framework everyone uses: pre-renal, intrinsic renal, and postrenal causes.
Pre-renal, intrinsic, postrenal. Okay.
Think of this as problems before the kidney problems in the kidney itself, and problems after the kidney that block urine flow.
Let's start with prerenal. What sorts of things fall into that before the kidney category? Problems getting blood to the kidney.
Exactly. This is all about inadequate blood flow to the kidney's renal hypoperfusion.
Yeah.
The kidneys aren't getting enough input to filter properly.
Like what? Volume loss.
Yeah. Causes listed include anything that causes volume depletion, like severe bleeding, hemorrhage, vomiting, or burns.
Okay.
It could be conditions where blood isn't effectively circulating, even if there's technically enough fluid, like in heart failure or cirrhosis, those edematous states.
Right, the pump isn't working or the fluid's in the wrong place.
Precisely. Severe low blood pressure from sepsis or anaphylaxis obviously reduces kidney flow. And even common medications like NSAIDs or ACE inhibitors can constrict the blood vessels leading into the kidney, reducing flow.
So anything that reduces the volume or pressure of blood getting to the kidney?
Okay.
What about intrinsic renal damage within the kidney tissue itself?
So here, the problem is in the kidney structure. This includes damage to the filters, the glomerular diseases like glomerulonephritis.
Inflammation of the filters.
Right, or damage to the tubules. Acute tubular necrosis, ATN, often from prolonged low blood flow or toxins.
So the pipes inside are damaged.
Yeah. Or inflammation in the spaces between the tubules. Acute interstitial nephritis, AIN, commonly caused by allergic reactions to drugs or infections.
Okay.
Diseases affecting the kidney's blood vessels, like vasculitis, and even conditions like eclampsia during pregnancy.
Okay, so filter, tube, or surrounding tissue damage, and postrenal blockage after the kidney. Downstream problems.
Exactly. Urine is being made, but it can't drain away, causing back pressure that damages the kidney.
Right.
Think of anything that can block the urinary tract.
Like kidney stones.
Yep, kidney stones, calculus, blood clots, strictures in the tubes like the ureters or urethra, prostate enlargement, or cancer blocking outflow from the bladder.
Common in older men.
Very. Also bladder tumors or external compression from things like radiation fibrosis or pelvic malignancies, even retroperitoneal fibrosis.
So prerenal flow to, intrinsic damage in, postrenal blockage after.
The material you sent has a really interesting point about the most common cause in the community.
It does, and it's a really high-yield fact. The vast majority of community-acquired AKI, up to 90%, is actually prerenal.
90%. Wow.
Yeah. It's often due to things like dehydration, simple infections leading to fluid loss, or mild sepsis, where hypotension reduces kidney blood flow.
Okay.
And common medications like ACE inhibitors or NSAIDs, which people might take routinely, can push a vulnerable kidney over the edge in that situation.
That's a crucial takeaway. Don't just think about complex kidney diseases when you see AKI, especially outside the hospital. Think fluids, sepsis, drugs first.
Absolutely. For a memory aid, maybe that plumbing analogy works. Prerenal is issues with the pipes to the tap.
Intrinsic is problems with the filter or the tap itself.
And postrenal is a blockage in the drain after the tap.
Yeah, that works nicely. So who is most vulnerable to this plumbing going wrong? Let's look at the risk factors. Okay. There are general risk factors listed. Older age, already having some degree of chronic kidney disease, diabetes, hypertension, heart failure, liver disease.
The usual suspects for chronic illness, really.
Pretty much. Also taking certain medications known to be nephrotoxic, having an infection, or exposure to contrast agents used in imaging.
And there's a specific list of elevated risk criteria, which feels even more targeted. Things that should really make you pay attention.
These are the patients where your clinical antenna should really go up. The material lists things like undergoing emergency or major surgery, having established CKD with an eGFR below 60.
Okay, so CKD 3B or worse.
Right. A history of previous AKI, being oliguric, making very little urine for any reason, cognitive impairment, or limited fluid access.
Meaning they might struggle to stay hydrated on their own.
Exactly. Being hypovolemic, recent exposure to specific nephrotoxic drugs like NSAIDs, aminoglycosides, ACEI, or diuretics, having had iodine-based contrast in the last week.
That contrast agent point keeps coming up.
It does. Also, symptoms suggesting urinary obstruction, sepsis, deteriorating vital signs on early warning scores, and simply being over 65 years old.
That's a comprehensive list. For you listening, identifying these risks early is absolutely vital because it allows you to proactively monitor and potentially prevent AKI.
Absolutely. Knowing someone is high risk means you're already watching their creatinine and urine output closely. You're being vigilant.
Briefly, let's touch on the pathophysiology. What's actually happening to the kidney tissue when these things occur? What's the mechanism?
Well, the material notes the key mechanisms. Ischemic injury damage from lack of blood flow.
Makes sense with prerenal causes.
Exactly. Inflammation, toxic injury damage from harmful substances like drugs or toxins.
Which can cause ATN or AI.
Right. And obstruction causing physical pressure damage. Essentially, these insults impair blood flow within the kidney, damage the kidney cells themselves, and disrupt their ability to perform their normal functions of filtering and balancing.
Leading to the dysfunction we see clinically. Got it. So, when you suspect AKI based on the signs, what other conditions might present similarly, or what are the main things you need to differentiate between the differential diagnosis?
Based on the causes, the main differentiations you need to make are between prerenal azotemia, that's AKI, due to reduced blood flow where the kidney tissue isn't yet permanently damaged.
Okay, potentially reversible quickly with fluids.
Right. Then, acute tubular necrosis, where the tubules have been damaged, often from prolonged prerenal failure or toxins, glomerulonephritis, inflammation of the filters, and obstructive uropathy, a blockage.
And differentiating these four is key because the management is completely different for each. How do we start to tease them apart?
Yeah, it really starts with history and examination, looking for clues like recent fluid loss, drug exposures, signs of systemic disease, or urinary symptoms like pain or difficulty passing urine.
Okay, the basics first.
Then, your initial investigations, particularly urinalysis, is crucial. And sometimes urine tests like osmolality or sodium can give clues. Imaging like ultrasound is vital to rule out obstruction.
We'll come back to investigations in more detail. Let's talk numbers. How common is this AKI, the epidemiology?
It's very common in UK hospitals, especially among critically ill patients, and strongly linked to increased illness and death, so morbidity and mortality.
Okay.
The data shows over 15% of emergency admissions already have stage 1 AKI.
15% on arrival.
Yeah. And surprisingly, community-acquired AKI is up to 3 times more common than AKI that develops after someone is admitted to hospital.
That community statistic is really eye-opening, again, reinforcing the importance of recognizing it outside the hospital.
It really does. While hospital data suggests about 2.4% of admissions have AKI coded, standardized estimates put the true prevalence closer to 14%.
So it's likely undercoded or under-recognized sometimes.
Probably. And the incidence is rising, partly because our population is aging with more comorbidities, but also because we're getting better at detecting it with widespread electronic creatinine monitoring.
Right, we test for it more. So common, serious, often starts before hospital and increasing. What does a patient with AKI actually look like? Clinical presentation.
The presentation varies depending on the cause and severity, but there are key things to look for. General signs listed include decreased urine output, oliguria, or even anuria.
Okay, the obvious one.
Fluid retention leading to swelling, edema, symptoms from electrolyte imbalances, fatigue, confusion, often due to uremia and nausea, and shortness of breath, often from fluid overload.
And specific symptoms and physical signs from the list.
Usually it's that reduced urine output, though sometimes paradoxically polyuria can occur depending on the specific cause, like recovering ATN.
Interesting.
Nausea, vomiting, and dehydration are common symptoms if it's prerenal. On physical exam, you might find high blood pressure, particularly with fluid overload.
Or low blood pressure if they're septic or dehydrated.
Exactly. In postural cases, abdominal exam might reveal a large, painless bladder if there's chronic retention. Dehydration signs include postural hypotension, dry mucous membranes,
and fluid overload.
Fluid overload gives you raised neck veins, the JVP, and fluid in the lungs, causing crackles, pulmonary edema, or swelling in the ankles, peripheral edema.
Any other clues on exam?
Other signs like pallor, maybe suggesting anemia or rash or bruising, could point to systemic conditions causing the AKI. And in severe AKI, you might hear a pericardial rub from uremic pericarditis.
These signs and symptoms are what should make you think AKI and prompt those tests that meet the formal recognition criteria we discussed earlier, that specific rise in creatinine or fall in urine output.
Exactly. They are the clinical triggers.
So once you suspect it, how do you investigate to confirm and find the cause? Investigations for AKI.
The approach, as laid out, starts with a thorough history and physical examination. That's your first and most important investigative step. Don't skip that.
Absolutely. Then the initial lab tests.
Essential tests are serum creatinine and BUN, or urea, to quantify the kidney dysfunction and track the trend. Urinalysis is absolutely crucial.
What are we looking for on the dipstick?
A dipstick can flag blood, which might suggest glomerulonephritis or stones. Nitrates or leukocytes point towards infection. Glucose or protein could indicate diabetes or underlying kidney damage.
And microscopy.
Looking at the urine under a microscope for cells or casts. And measuring its osmolality or sodium concentration can help differentiate prerenal from intrinsic causes, like ATN.
Okay. What about broader blood tests?
Based on your suspicion from the history and exam, you might need a full blood count and blood film, looking for anemia, infection, signs of blood disorders. UNEs are vital to check electrolytes like potassium and assess severity.
Right. Hyperkalemia is a big wordy.
Huge coagulation studies, especially if bleeding or specific intrinsic cause is suspected. Creatine kinase or checking for myoglobinuria if you suspect rhabdomyolysis is a cause of ATN. And CRP for inflammation or infection.
And sometimes you need more specific tests. Immunology, virology.
Yes, if you suspect systemic causes for intrinsic kidney damage, like autoimmune diseases or infections, this is where immunology tests come in, things like ANA, complement levels, anti-GBM antibodies if you suspect good pastures, and virology tests like Hep B, Hep C, HIV.
But these aren't routine for every AKI.
No, definitely not. They're guided by history and initial findings like protein or blood in the urine or systemic symptoms.
They also mention those new biomarkers in the notes.
They do. Things like cystatin C and GAL, KIM1, IL-18. But importantly, the material notes that none of these are currently recommended for routine clinical use in diagnosing or managing AKI. Stick to creatinine and urine output for now.
Got it. What about imaging? You mentioned ultrasound.
Ultrasound is your key imaging modality, particularly important if you suspect obstruction or the cause isn't clear from initial tests. It's non-invasive and can easily visualize dilated ureters or renal pelvis behind a blockage.
So rule out obstruction first.
Pretty much always, unless the cause is blindingly obvious, like severe dehydration that responds immediately to fluids. Other imaging might be needed depending on the context. Chest X-ray for pulmonary edema, non-contrast CT or NCCT for suspected kidney stones. Crucially, the notes emphasize avoiding contrast in AKI unless absolutely necessary because contrast itself can worsen kidney injury.
Right, contrast nephropathy.
Exactly. Maybe Doppler ultrasound for suspected blood vessel issues in the kidney or MRA, but those are more specialized.
The critical point throughout the investigations and the entire process is figuring out the cause, isn't it?
Absolutely. Identifying if it's due to obstruction, hypovolemia, a specific drug, or an intrinsic kidney disease is paramount because management hinges entirely on addressing that underlying problem.
Okay, let's move to management then. What are the core principles once AKI is diagnosed?
Number 1, address the underlying cause. Number 2, optimize fluid and electrolyte balance. Number 3, provide supportive care while the kidneys recover or until specialist intervention is needed.
And the main strategies to achieve that? Fluids, meds.
Administering intravenous fluids if the patient is dehydrated or hypovolemic is key for prerenal causes. Meticulously adjusting medications, that means stopping any potential nephrotoxins.
Like those NSAIDs or ACE inhibitors we mentioned?
Yes, stopping them if they might be contributing, and adjusting doses of any drugs that are cleared by the kidneys because they'll build up otherwise.
Okay. And for severe cases?
If severe complications arise, like life-threatening hyperkalemia, severe acidosis, or massive fluid overload unresponsive to diuretics, then initiating renal replacement therapy or dialysis becomes necessary.
The material provides clear UK guidelines on who needs specialist input, who warrants urgent admission or referral.
Anyone with stage 3 AKI should usually be discussed or admitted. Also, if you suspect obstruction and there's also infection, there's a urological emergency. If the cause isn't clear after initial assessment. If there's a high risk of urinary tract obstruction that can't be easily managed, if sepsis is contributing significantly, if there's significant hypovolemia that isn't quickly corrected, or if complications of AKI are present, like pulmonary edema or severe hyperkalemia.
And immediate referral for upper tract obstruction complications.
Yes, that needs urgent urology input.
And when should you pick up the phone and discuss with a nephrologist, even if not necessarily for immediate admission?
Good question. If the patient has underlying stage 4 or 5 CKD, if they require specific specialist treatments like immunosuppression for suspected glomerulonephritis, if they aren't responding to standard management.
So creatinine's still climbing despite fluids, etc.
Right, if they develop significant complications. Or if they're a renal transplant patient, any AKI in a transplant needs urgent nephrology discussion.
And for milder stage 1 AKI in a patient without these red flags who maybe isn't admitted?
You manage the likely cause, maybe hold certain meds, encourage fluids if appropriate, provide supportive care, adjust any necessary medications, monitor creatinine closely, maybe daily initially.
Okay.
And consider specialist input if things aren't improving or the cause remains uncertain even in stage 1.
Any specific drug rules in management based on the notes? Diuretics, dopamine?
Yes, two important ones. Avoid routine use of loop diuretics to treat AKI itself. They don't make the kidneys work better.
But you can use them for fluid overload.
Yes, they can be used cautiously to manage fluid overload symptoms while waiting for recovery or dialysis, but they don't fix the underlying AKI. And definitively avoid low-dose dopamine. It's been shown not to be effective for treating AKI.
Okay, so don't try to kickstart the kidneys with those drugs. Focus on the underlying problem and supportive care. The material reinforces specific reasons for nephrologist referral again later.
Yes, it lists them quite clearly. Patients with renal transplants, AKI of unknown cause, especially in ICU, specific intrinsic diseases like vasculitis, glomerulonephritis, AIN, myeloma kidney. Also, if the cause is unknown, despite investigation, if treatment isn't working, if complications develop, stage 3 AKI, underlying stage 45 CKD, or if they qualify for RRT due to complications, it's quite comprehensive.
And a note about pediatric.
Yes, in children and young people who recover from AKI, referral to a pediatric nephrologist is needed if they are left with complications like hypertension, ongoing impaired kidney function, or significant protein in their urine.
Suggests long-term follow-up is crucial for them.
Definitely.
So all roads lead back to addressing the underlying cause as the cornerstone of management.
Absolutely. Supportive care buys time, stops things getting worse, but fixing the root problem is what allows the kidney to potentially recover.
How about the future? What's the prognosis for AKI? Does everyone recover?
The outcome really depends. It depends on the cause, how severe the AKI gets the stage, the patient's other health problems, their comorbidities, and critically, how quickly and effectively it's treated.
So prompt action is key for a good outcome.
Massively. The material highlights that prompt recognition and management significantly improve the prognosis. However, if AKI isn't managed effectively, or if the insult is too severe, it can unfortunately lead to chronic kidney disease or even end-stage renal disease requiring long-term dialysis or a transplant.
So AKI can become CKD, and the mortality data is quite sobering, isn't it?
It is. It varies greatly depending on the setting, the cause, the patient. But a hospital study mentioned showed an overall mortality of nearly 24%.
Wow.
And look at the difference by stage, though. 16% for stage 1, but a stark 36% for stage 3. That's more than a third dying in hospital if they reach stage 3 AKI.
That jump in mortality between stages really drives home the importance of catching this early, preventing progression.
Absolutely. And while community AKI has lower direct mortality, the notes say it still increases a person's overall risk of illness and death long term.
And the material makes this point explicitly about prevention.
Yes. Early detection can prevent up to 30% of AKI-related deaths.
30%. That's a huge potential impact. It makes the prevention aspect incredibly important.
What does guidance like 9C suggest for preventing AKI again?
The key steps are proactively identifying patients at risk, using those elevated risk criteria we discussed earlier.
Right.
Monitoring urinary output and serum creatinine regularly in these vulnerable patients, avoiding nephrotoxic drugs and contrast agents whenever safely possible in at-risk individuals.
And if contrast must be used.
If iodinated contrast must be used in someone at risk, the guidance suggests giving them intravenous volume expansion IV fluids beforehand to try and protect the kidneys.
Identify, monitor, avoid, and protect. That seems like a clear framework for prevention.
It is. And it's where you, the clinician listening, can make a real difference in preventing those higher stages and the associated poor outcomes.
Finally, let's quickly cover the potential downsides. If AKI isn't managed or is severe, what can go wrong? Complications.
The material lists serious complications across several systems. Metabolic issues include uremia, the buildup of toxins causing confusion, nausea, etc.
Metabolic acidosis, where the blood becomes too acidic because the kidneys can't excrete acid or retain bicarbonate. And hyperkalemia, dangerously high potassium, which can cause cardiac arrhythmias.
That high potassium is really the immediately life-threatening one.
It certainly can be. Then there are fluid and cardiovascular issues. Fluid overload can precipitate heart failure or arrhythmias.
Makes sense.
Other complications listed are general electrolyte imbalances beyond potassium, increased risk of infections because patients are often sicker and more vulnerable, progression to chronic kidney disease, as we mentioned,
All right.
bleeding issues, partly from uremia affecting platelets, pulmonary edema from fluid overload, prolonged time in hospital, and overall increased risk of death.
That list really shows how interconnected kidney function is with the rest of the body. When the kidney fails, multiple systems suffer.
It underscores the severity of AKI and the importance of managing it aggressively to mitigate these widespread effects.
Okay, we've covered a tremendous amount of ground, diving deep into this revision material on AKI. We've gone from defining it and staging through causes, risks, presentation, investigation, management, prognosis, and complications.
We've aimed to make this detailed information into a clear, high-yield review, hitting the key points you'd want to remember for understanding AKI clinically or for revision purposes.
It's clear that AKI is a really common and serious issue in healthcare, with diverse causes and presentations. Identifying who is at risk and intervening early really is crucial.
It directly impacts prognosis and prevents those serious complications. Understanding the staging and the different etiologies helps guide your entire approach from the beginning.
By breaking down this information, we hope you feel more confident in approaching AKI, knowing what to look for, how to start investigating, and the core principles of management.
Absolutely. And thinking about everything we've just discussed, especially that significant mortality linked to higher AKI stages, stage 3 particularly, and that powerful statistic that early detection can prevent up to 30% of deaths. Here's something to consider for yourself.
Okay, a final thought.
Yeah. What one small practical change could you implement today, either in your clinical practice or your study routine, to improve your personal early recognition of AKI in those at-risk patients we talked about?
That's a good challenge. It could be something as simple as adding a mental trigger when you see a patient with sepsis or who's elderly and dehydrated.
Or maybe setting a reminder to specifically check the creatinine trend, not just the latest value, on a specific ward round or patient review.
A little deliberate thought early on can go a very long way. If you're looking for more high-yield revision material like this, designed to help you consolidate knowledge efficiently,
Check out passthemsra.com and freemestry.com.
you'll find resources there specifically tailored for revision like this deep dive.
Thanks for joining us for this deep dive into acute kidney injury.
We hope it's been helpful for your learning journey.